afternoon. The title of my presentation is A Rare Cause of Fatal Gastrointestinal Bleeding Case Report. Contents are introduction, history of the case, autopsy findings, discussion and conclusion. Rupture of esophageal varices following alcoholic liver disease commonly causes gastrointestinal bleeding. We had a case where a person presented with history of gastrointestinal bleeding suspected to be died of rupture of esophageal varices, and at autopsy autopsy revealed an extremely rare fatal condition associated with a common finding. History of the case: a 48-year-old male chronic alcoholic was presented to a local hospital with history of hematemesis and bleeding per rectum. They suspected liver disease and he had hemorrhoids also. He was treated as outpatient, and on the very next day he was brought dead to the casualty. Coming to the autopsy findings, body was pale. There were streaks of altered blood extending from the nostrils. He had hemorrhoids, dry blood stains seen around anal orifice as well as adjoining part of thighs and buttocks. Postmortem staining was very faint at back. Internal examination: there was ulcerated atheromatous plaques in the abdominal aorta below the origin of renal arteries with infiltration of blood around. On further examination, there is a communication between this ulcerated plaque and adjoining third part of duodenum. This arrow shows the opening of the communication or fistula into the duodenum, third part of duodenum. As we suspected rupture of esophageal varices, we had taken stomach along with the esophagus, and it contained 250 ml altered blood with 123 gram blood clot. Small intestine also contained blood with clot. Liver showed fatty change and all other internal organs were pale. Histopathology was done. This is a histopathology slide of region of fistula. Here you can see the aortic tissue. This is the duodenal tissue. This circle shows the fistula region with aortic and as well as duodenal tissue and inflammatory cell infiltration. Opinion as to cause of death was given as death was due to hemorrhage following aorto-duodenal fistula. Coming to the discussion, aorto-duodenal fistula is defined as direct communication between abdominal aorta and distal part of duodenum. The most common site is the retroperitoneal fixed third part of duodenum, which lies anterior to aorta. It may be either primary or secondary. Primary is spontaneous following disease of aorta like abdominal aortic aneurysm. Incidence rate at autopsy is 0.04 to 0.07%. Secondary occurs following aortic prosthetic reconstruction, and the incidence rate after surgery is 0.5 to 2.5%. Mechanism of fistula formation: atherosclerotic aortic aneurysm causes release of abundant amount of metalloproteinases. This will result in inflammatory cell infiltration and fibrotic adherence to the duodenal wall, causing pressure necrosis and formation of aorto-duodenal fistula. Symptoms are gastrointestinal bleeding. It may be intermittent self-limiting heral bleed or massive bleeding. Heral bleed occurs due to the occlusion of a small thrombus, occlusion of the small fistula by thrombus along with the contraction of the intestine around it. And after dislodgement of thrombus, massive bleeding occurs. Other symptoms are abdominal pain and abdominal mass. In the present case, there was history of gastrointestinal bleed, atherosclerosis present in abdominal aorta. There was primary aorto-duodenal fistula, and fluid blood with organized clots seen in stomach and intestine. Organs showed features of exsanguination, and diagnosis was confirmed with histopathology. Take home message: aorto-duodenal fistula causes sudden natural death. It is an extremely rare fatal complication of atherosclerosis of aorta, which is a common pathological condition, and careful examination of adjoining organs are also necessary in case of bleeding from gastrointestinal tract. These are my references. Thank you. It cannot be detected. It can be only detected by CT scan of the abdomen.
Even if the patient is subjected to ultrasound scan, it may be missed.
May be missed. And this is
Whether the patient is hypertensive?
no history of hypertension, only history of alcoholism.
If a Doppler was done, it leaking anteriorly, if there is a sense of looking at the patient and the condition, it can be identified.
It is very difficult to
identify. It is difficult, especially with ultrasound it is not. Yeah. But with a
CT
angiogram will give you a diagnosis, like if there was a thrombus occluding it, and or even an ERCP showing the blood from a particular region could be able to clinch your diagnosis.